So now, I agree that Ullas treats and stays in a five-star hospital. So he doesn't know the reality of India actually. So let me just put into, I saw that chat which you showed Ullas, but fact is when you talk to the patient, they ask you, Doc Saab, kitna kharch hoga? And that is a part of the science. That's why you have a term, Ullas, called pharmacoeconomics. And that is how it is done, because nothing comes for free. So now, is osimertinib the best option for first-line treatment in EGFR mutation advanced lung cancer in 2022? Before I start, Ullas has eaten 20 minutes of the debate time, Vijay, and that is what it is. Because he had to speak so much to convince everyone, because there was nothing to, because people were not convinced. So what he did was, he spun a fairy tale about the drug called osimertinib. And that is something that Ullas needs to remember. These have been only fairy tales which you spoke about. So now, let's come to combination. Is there a rationale? Is there evidence and its level of evidence? Is it applicable to all? Toxicity, which he spoke about, I'll speak about the toxicity which Ullas did not mention about. He spoke about neutropenia as he has never seen a neutropenia. He did not speak about febrile neutropenia. And that's what all of us are concerned about. I am not bothered about a 2000 TLC which comes to my OPD on day 8, because all these trials have this documented weekly CBCs to be done, but they don't have fever. Do you admit them, Ullas? No. Do you give them anything? Max, you tell them go home, or some of our oncologists who give them a GCSF. That's also without evidence. The cost benefit analysis is something which Ullas, I will show you, and probably that will open up your eyes to the world, and that's how it should be. So is there a rationale first? If you look at it, that is a definite rationale for combining chemotherapy to the TKIs. And it has shown that they have a synergistic effect. And that has been well proven in the preclinical studies. So first, is there a rationale for combining? Yes, there is a rationale for combining. So let's look at the NEGH009. I knew that the update thing was there. I should not have told you in the morning, and then you would not have put this up. So I did not, but yes, if you look at it, this is the data which has shown the maximum survival of around 51 months. It's not 53, now it's 51 months. And that is something that we need to remember. That landmark, I didn't hear you, Ullas, you never spoke about the Flora OS. Ullas, it is 37, 38. Ullas, kitna tha ye? Flora ka OS? Ullas, you are muted?
You want me to say that?
Yeah, please. OS in Flora was how much?
38.
Ah, great. So now we record
comparison, Dr. Sahoo.
So now Ullas, mute yourself. Now Ullas, mute yourself. Okay.
Dr. Ullas, let's Sahoo continue, please. You'll get your rebuttal.
So now, this is what it is about the TMH. I'm speaking just to the OS. He spoke about the toxicity. He spoke about Tata Memorial, which many people did not tolerate the 4 doses of chemotherapy. That's because Dr. Ullas, they were brave enough to take a real life scenario of 20% who was PS2. And that's something, the reality of the life. And if you look at it, the presence of brain metastasis were around 20%, which accounts to the radiotherapy usage which you spoke. And all of us know that symptomatic brain mets, you would go for a radiotherapy, and definitely in a government hospital. And in the Indian scenario, WBRT is the way to go ahead. So that probably answers the part of which you told about. But in spite of having 20% patients who were PS2 and 20% who had a brain metastasis, still they could achieve their PFS and OS data. And mind you, the hazards, I'm not looking at absolute values here. The hazards for the TMS data was around 0.5. And that's what I want to remember, that there's a 50% benefit of giving a combination versus a gefitinib. And I will show you the hazards of our favorite trial called Flora. And if you look at the Chinese, this was again the design, and look at the hazards, again sitting on the 0.56. What I see in the whole thing is, I'm looking at a drug combo which is consistently across trials showing you a definite hazards of around 0.5, 0.6. And that is what it is, that multiple trials have shown you one simple thing. You have a 40 to 50% benefit of a combination versus the single agent TKI, which, mind you, Flora did not show. It was a peer for 20% benefit. That's 0.8 hazards. And look at the Flora and look at the analysis. And this is what I was speaking about. It is 0.799. That's the OS. And mind you, the hazards of OS compared to the hazards which I showed you. And do not forget, The initial hazards which was shown for OS in FLORA, the interim analysis was 0.6. This has actually fallen. Two more patients on this side, Ullas, the CI would have just crossed the line of 1. And if you look at the confidence interval, it is 0.641 to 0.997. Just missed it. I don't know whether they took out two patients to even fulfill these hazards. That's something which I am not have evidence, so I cannot accuse them of that. You showed this lovely PFS data. All of us agree. Look at the PFS across the combination. It is really the same. Yes, I will speak of subset analysis because my patient is one of the patient in that subset. My patient is either having that L858R mutation, or is a Asian, or has the PS2, or has a brain mets. Like you told in leptomeningeal, you look at a particular drug. So subset analysis is the essence of how you want to treat. So look at the subset analysis for OS Ullas. You showed us all those lovely forest plot. This is Ullas of FLORA trial. Is anything even not touching the line of the one line? No, it is all across. You don't have anything that is falling into the left side of Osimertinib. What were we showing for that hazards or forest plot Ullas? This is the FLORA forest plot, which is showing that nothing actually is better. And if you look at the Del 858R, and this was actually sitting on the 1. And look at females, you spoke about it. See this female thing, it's again crossing the 1. So what you're speaking of OS also is applicable for the FLORA. But look at the same OS thing for the TMS data. Everything is nicely sitting on the left side, which is favoring the combination. And if you look across the OS for the Chinese data, again favoring only the combination arm. So what I meant to say is response rates. Let's have a look at the response rate. And these patients are basically bulky disease. My patient load are very sick. They come to us late. I would have to have lovely responses. You look the responses across, they are looking to the 75 to 80% of these data, and look at all the data which you look across the combination is sitting around 80-85%. The FLORA is sitting at around 70-75. So I would look at a more effective response rate if I use as a combination, which probably we have seen across these subsets. Now we are talking of immunotherapy and chemotherapy combinations also. The CNS, agreed, this is a giveaway that the Osimertinib has an advantage, but it does not mean my combination does not work with the CNS disease. And look at it, the Chinese have shown that, the TMS data has shown that in CNS metastasis, the combination of Gefitinib and the chemotherapy does do good, and the hazards is very, very impressive. This is very important for me. People have to see this slide. If I have a treated CNS mets, already known mets, I probably have better benefit of Osimertinib. But the new CNS disease means not the patients who did not have CNS at entry for a FLORA. I don't think there is much of a difference in the Gefitinib versus the Osimertinib data. The difference is mainly the patients who already had CNS disease as presentation to develop the recurrence of the CNS disease. That was something I feel the Osimertinib did help. Asians, non-Asians, I have to speak of that because half the world is not sitting in the US or Europe. They are sitting in this part of the world, which is Asia. And if you look at it, it has been a dismal response. And if you look at it, the data for the FLORA, for the two subsets of Asia and the L858R, it's horrible. Look at the Chinese. You showed the Chinese data, but you probably, because I told you today, you did not read the whole article. You just read the headlines. And look at what I'm looking at. The OS for the Chinese, as again the hazards is around 0.8 to 0.85. And this is statistically insignificant. I concede it was not powered for that. But look at the hazards. The benefit is poorer than the OS benefit, what you see in the whole population. And look, this is the Chinese FLORA. This is the Chinese FLORA Ullas. And look at the EGFR mutation. Again, the same thing comes around, even on the PFS, that it is not a very active drug on L858R. And the OS is again the same. It is just a dismal drug. And you spoke about how many in the TMS data got Osimertinib. I want to tell, in the trial, in like FLORA, where had the drug, they had the opportunity to give everyone Osimertinib. Only 30% of the patient post Gefitinib failure receive Osimertinib. And mind this, take this into context with the OS has this confidence interval which I showed. If 60% of this patient, 60% of this patient who were eligible for Osimertinib would have got Osimertinib on progression for Gefitinib, I'm pretty sure your OS would have been sitting and the hazards would have been 1.2 in favor of the gefitinib followed by osimertinib. So this is the reality. When you want to skew a trial, do not provide osimertinib post progression. You just give half the patients osimertinib when the flora or sponsors could have given it to all the patients. So this is something very important. Why not first line? You told of the rare mutations. Tata had the rare mutations. Even I have a better drug called than osimertinib, afatinib. I would probably give that. I would probably have a real life data of the geotag trial. Although with all the criticism, it has shown a benefit of OS which we have not seen in the real life scenario. 45 months to 50 months, and this is something which is very, very important. And now I have 2-3 more slides. Look at if I rank it as per the OS data. If I go for it, the way the OS data has come, the 52 months is the NEJ009 for Japan. It is 52 months, so it takes the gold position for me. The second position I would give to my erlotinib and bevacizumab combination. That is it. Second, and the third will go to my TMH guys or the Chinese guys or the sequential geotag. And Ullas, with all your effort, you still miss the bronze. You will be the Milkha Singh of the Rome Olympics who just missed the bronze medal. And then come down to this one population. Ullas, we spoke about, we debated together when we had COVID. Now post-COVID, do you know this data from the Japanese relay subset? This trial shows you that when they gave a erlotinib-like thing, it was 0.1% for interstitial lung disease. And if you look at the flora subset of Japanese trial, it was 12% interstitial lung disease. Ullas, is it easy to treat interstitial lung disease? And you have 12.3% of the patients in the Japanese subset of flora who had interstitial lung disease. In Chinese trial, that even did not mention the word ILD. I would love to see that. I'm very sure the ILD in the Chinese flora also would have been the same. So are you saying that is a safe drug? Do you know what is the quality of life for ILD patients? Now coming to the reality, cost effectiveness. Even a country like US and Brazil, the cost effective studies told that in US you need to discount the drug by 20%, not cost effective. If you come to against a study like for osimertinib cost effective for US and China, it is not cost effective. For UK, it's only cost effective for second line, not for first line. So across the world, at the cost it is given, it is not a cost effective drug. Last, some more facts. We live in a country called India, and we all love our country. It is shining, but is it really that much shining? We still are very poor in our poverty index. We still are not as good in the money in the pockets as some other countries. We are 99 out of the 180 odd countries. In the global multidimensional poverty index, we are in the last 5. So we have to take things in context. Osimertinib for me would cost me 30 lakhs 60,000. Very few of us could afford it in my country. Afatinib followed by osimertinib could be something little more costly, but my pemetrexed carboplatin gefitinib Ullas is around 2.76 lakhs, and that is also for 1 year of therapy or maybe 1.5 years of therapy. I think even the BPL, the Ayushman Bharat also agrees to that fact. That's why this is the only combination they put it. So this gives me validation that in India, even a government program only has validated this combination. So now the choice is yours. So I end up with, is there a rational Ullas? There is a rational. Is there evidence? There is evidence. You showed only one trial. I've showed you 7 trials. What more do you want? Is it applicable to all? It is applicable to all. Across subset, across subtypes, across Asians, non-Asians, Westerners, it is there. Toxicity, there are issues with toxicity, but that was nothing that we could not handle. There were paper toxicity, and the discontinuance rate was something that I would not be very much worried about. Cost benefit, is there any other doubt? US also tells you that we need a drug 20% cheaper. What more would you say of cost benefit analysis? So last, this is how you are looking now, or even on the screen. You are not able to realize, take a screenshot, see it later, and you will always see that you have been looking like, it's easy, exactly, take a screenshot now. And this is how you're looking actually. So this is, Arey, ye kab hua yaar? Ye kab laga mere ko yaar? This is what the reaction is. So bhai log, all the listeners, jago doctors, jago. Ullas is sitting in a 5-star hospital. We are the doctors treating the general population, treating the poor. And if I can do it at 10% of the cost which Ullas is spending, I feel we are doing a better job, Ullas. And I do not have to recommend something that makes my patient BPL the next year and makes him eligible for the Ayushman Bharat next year, although he was eligible with the card this year. So with that, I stop here. And thank you, Ullas. It was always lovely debating against you.